Welcome to Protech's Resiliency Dialogues workshop series. I'm Helen. I'm one of the principal investigators of Project Protech, and we are very excited to have a very distinguished panel with us tonight to talk about one of the most central and important topic that concerns our community in the pandemic, which is about the care for our seniors. Um, and how can we have a more organized and better responses um, to the pandemic. So we have Susan Ng, who is a long-term community leader and activist and advocate on many, many issues, but she's also been at the forefront of advocacy for senior care for over 2 or more decades. We have John Yip, who is the CEO of Kensington Health. And we have Helen Lee, who is also a long-term community activist and a colleague of us from the Chinese Canadian National Council. But for Protech, we are especially privileged to have her here because the story of her and her grandmother has been on the front page of Protech's web page since the very beginning. So we look forward to a very dynamic discussion on the issues related to our seniors care. But before we start, we would like to do our short poll so that we can get a sense of our audience and participants. So if you can please do that, that would be much appreciated. And then if we can invite our colleague Rain to do the land acknowledgement.
So with gratitude and respect, our team here at Protech honors and acknowledges that we are gathered on this sacred land covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaty, signed with multiple Mississaugas and Chippewa hands. Toronto is located on a dish with one spoon territory, a treaty between the Anishinaabe, Mississaugas, and Haudenosaunee that bounds each other to share the territory and protect the land. Subsequent Indigenous nations and newcomers were invited into this treaty in the spirit of peace, friendship, and respect to share and care for the resources of this land. We are aware of the ongoing impact of colonialism, racism, and other forms of discrimination and social justice that disproportionately impacts Indigenous people, as well as other racialized communities here on Turtle Island, also known as North America. We stand in solidarity to continue our fight against anti-Indigenous, anti-Black, anti-Asian, Islamophobia, and any other forms of racism and social oppressions locally and globally. So we have some guidelines here as well for our session. We hope that all of you will be able to follow this. We definitely do not tolerate any online harassment of any kind. If you have any questions on the side there in the chat, you can click the drop-down menu, which says all panelists and attendees. And if you want to speak, you can also let us know, and then we can turn on the mic for you so that you can speak with us. There is also a raise hand button there as well. Under participants. In the older version, it's under participants, and the newer version is in the reaction bar. So make sure you're, if you are speaking, make sure that there's no other distracting background noises, and obviously make sure we're respecting each other. Do not take screenshots of this conversation, or this will be recorded and it will be shown later on YouTube, so there's no need to take any screenshots of recordings. And if anyone is disrespectful of others and do not take accountability, they will be removed. Yeah, thank you for listening.
Thank you, Rain. And so again, like we would like to maximize our time for our distinguished panel. We have prepared some scenarios just to get us to really look at the bigger context of how our senior population's been impacted by the pandemic. I would just like to invite our panelists to maybe briefly introduce themselves. Um, I always do that because like if, you know, with their distinguished career, I would not do that justice. So I'm always passing the buck for them to do that themselves. So maybe Susan, you can start.
Yes, thank you, Helen. Thank you for having me here. My name is Susan Eng, and currently I'm retired, but I am an advocacy fellow at the National Institute on Aging, which in particular has looked at a number of issues dealing with long-term care. Prior to that, I was head of advocacy for the Canadian Association of Retired Persons, and I was also one of the founding board members of the Yihon Community Health Organization and Center for Geriatric Care.
Thanks, Susan. John?
Thanks, Alan. Hi, everyone. Thanks for inviting me to this panel on a very, very important subject. So my name is John Yep. I'm the president and CEO of Kensington Health. We are a not-for-profit charity right in downtown Toronto that offers a range of community-based healthcare services from ophthalmology and imaging to more relevant to this conversation, 350 long-term care beds and 10 residential hospice beds. We have celebrated today the passing of 12 months since the onset of the pandemic. We have quiet reflection on the 12 residents that we did lose at Kensington over the past 12 months. We continue to manage the pandemic. It's been quite a year. A lot of people have committed themselves to protect our residents, our staff, to ensure that their lives remain as fulfilled and as full as possible to the extent possible at pre-pandemic levels. So I'm happy to share my experiences, my team's experiences throughout this panel. So thank you for having me.
Great, thanks, John. Thanks for being here. Helen?
My name is Helen Lee. I also retired a few years ago, but to help my grandmother, Fun Hei Lam, transition to a nursing home. She was in her own home, and she was 107 at the time. So my encore job is really a lot more challenging than my other job I left, and I've learned so much about long-term care. During wave one, I was the chair of family council at Mong Shong Darcy. It's a nursing home downtown Toronto that experienced a horrific outbreak very early, April, end of March. And we had 41% of the residents pass away. So that's 33 COVID deaths and 10 excess deaths within about a month. So it was very, very tragic. Prior to that, I had a lengthy career in human resources and change management in the Ontario Public Service. So today is the National Day of Observance for COVID-19 pandemic. And so it's been 1 year since the WHO declared the pandemic. And Alan, you had such good foresight to kind of schedule this session on that day. Amazing. And I just want to thank you for the invitation. It's a privilege to join Susan and John. John, you've done so much wonderful work for your home. And I look forward to the discussion that we're going to have.
Great, thank you so much. So we do really look forward to learning from all of you. So maybe just to get the discussion going, I know we've prepared some scenario that we wanted to, you know, kind of springboard our reflection and discussion on. So maybe Helen, you can start our first part of our scenario.
Okay, so these are like typical cases, and it's just to provide us with a framework for us to start our discussion, really. A 93-year-old elderly senior living in a nursing home that's faced an outbreak and locked down with the home, running short of PPE and having staff short, as some of the staff have gotten sick. So as a result of their lockdown status, family members were not allowed to visit in person. So
to gauge our responses or reflection, we'd like to get our participants to respond to some poll questions. If you're a family member, what might your response be? If you're working in the management of the nursing home, what might be your response? And what do you think the government should be doing? So if we can have the poll now, please.
1 second.
Ring. Okay.
Yeah, 1 second.
So you can scroll down and all 3 questions were there and you can select more than one options in all of those questions.
Maybe we can go back to the other slide with the case itself so that people can look at it in case they forgot.
And please feel free to type in your response in the chat box of additional suggestions and other comments. So we're still waiting for a few more to respond. If you can be generous in your sharing, that would be really helpful. So another suggestion is set up video chat facility at nursing home. So the poll will close in about 10 seconds. So please do share your thoughts. FaceTime using iPads, smartphones to families so that they can talk to their loved ones. Okay, so maybe we'll pass it back to our analyst and we can also see the poll results.
Okay, so the options were wait for nursing home updates, no news is good news, get in touch with your nursing home's family council, call your MP, reach out to the community agencies for help, storm the nursing home, and others where we had like iPad and video chat suggestions. So those are many of those things families have done in the outbreaks. I think in terms of what my experience, we've done them all except for storm the nursing home. So basically family councils can take and families can take, do a lot of outreach and communication. So lobbying your MPP, ministers of long-term care, the premier, calling Minister of Health, getting in touch with your MPP in your area to ask for more help, to bring visibility to the struggles that the nursing home's having. I found in my own experience, we had this organic thing happening with a sidewalk campaign that we started just to really raise awareness and to express our appreciation for the workers that were there. They come in and it's short staff, they still come in. And so we were on the sidewalks, family members were on the sidewalks, clapping, thanking them for coming in with the changes of shift. And we found that that was such a morale boost for the staff and for the families because we didn't feel helpless anymore, right? And it also added this team building thing where we started building community amongst ourselves. And so that was very, very good. Also, we did outreach to media and attended town halls and stuff like that. Twitter was a great experience in terms of the social media and connecting with families. I think when you're looking at a larger picture is I think families can also lobby for changes, like lobby for changes in terms of asking for national standards in long-term care, and ventilation, and linking it to a better accountability and enforcement scenario where there's inspections and there's follow-up and pushing for the accountability and the safety in terms of the home as well.
Thank you.
Yeah, and
So
different
maybe,
models.
yeah. Would other panelists like to share their thoughts on?
Yeah, I can jump in and add some other options that we did at Kensington Health. So one of the highest poll questions was having families come and support. And we agree. We feel families are an essential part of the care team, that many of the residents, your loved ones, rely on family members to support them in very basic needs like helping to feed, helping to stabilize, providing socialization. And that all stopped a year ago when family members were not allowed to come into our homes. Our team came up with what I thought was a pretty risky move. They suggested that we hire family members as residential aides. And my initial reaction, and Susan, you would appreciate this as a lawyer, was that this was a big risk. We consulted our labor lawyer who said, well, nothing's stopping you. We made sure we were not contravening the directives from government around restrictions. But we were very short-staffed, as the case study showed. So we offered 90-day temporary contracts to about a dozen family members who volunteered. We pay them a wage, but most of them donated it back to us, to our foundation. They went up on the floors, and not only did they take care of their loved one, they took care of the full 25-bed unit. They knew the family members knew them. So they trusted those who had volunteered to go up to also take care of their loved one. And what we saw was quite phenomenal. And that community that Helen talked about really came to life on the floor. To this day, we still have two of those family members still working with us and being true leaders on the floor, providing that essential family voice to our care teams.
Okay.
The other point I want to make that wasn't on the poll, and I know a lot of homes don't have this luxury, is I mentioned in an introduction that we have an ambulatory side. So we have registered nurses, registered practical nurses that help do surgeries. We had to close our surgical center during the pandemic for 3 months. And so we made a call to redeploy those staff into long-term care. Initially, there was a lot of hesitancy. So I actually was on the floor when normally we would have 7 or 8 staff members. There were only 2 that day that showed up. So I rolled up my sleeves and I became a residential aide. And I did that for a number of reasons. There was just no other option. But more importantly was to demonstrate that if I, as the CEO, could step into a COVID floor, then others could too. And when I showed this to staff, we had 20 volunteers sign up. And not just nurses, but finance, a world-class researcher, a retired firefighter, who also happened to be an ICU nurse, all stepped in to anchor that floor and to reinforce the depleted ranks on our COVID unit. I think people who work in long-term care are deeply committed and passionate about what they do. The staff are the lowest paid. You'd be surprised what wages they make. They work extremely hard. They are mostly racialized, so a lot of Asian, Filipino, Nepalese, Chinese, Black women. They're mostly women who have struggled through this pandemic. And so to see their colleagues across the way come and support them really gave everyone, including the residents and family members, a big boost in morale that they were there to help their fellow colleagues.
Wow, that's really inspiring, John. And I think that makes a huge difference to really see how, being agile, being responsive, and um,
Not waiting.
taking on that, visionary move is really something. There is a question from the participant. How did the union react when you hire family members?
Yeah, great question. Certainly we were hesitant. Fortunately, pre-pandemic, we had a very good union. It's CUPE, and we had done a lot of work to establish a good, solid relationship. We were very transparent from the get-go when staff members started testing positive. They were very, very receptive. In fact, we wrote a joint letter together to staff. Very unusual for management and the union to write a letter in support of bringing non-union staff to the floor. But I think that really showed that we cared about our staff, their members, and it doesn't matter whether you're union or non-union, it was our staff, and we care deeply about the people we serve. And so we were very lucky and fortunate for our union to support it. I've heard since subsequent to this that many unions and other homes did not support this, and it's very unfortunate due to the relationship that existed prior. But we were in a good spot to be able to partner with our union for a shared cause.
Mm-hmm. Well, that's another really groundbreaking visionary move too. I think it also must have depending on a lot of the goodwill and shared vision building that you've invested into that relationship, right? Yeah, thank you for sharing this. Susan, would you like to share some of your...
Alan knows what's coming. He invites me onto these panels, not for the good news stories, but for the things that we have to do. Those are indeed inspiring stories, and they are extremely good ones. And those two examples of families taking on responsibility and pressuring their particular system, a CEO taking direct responsibility for changing the circumstances in his home, also extremely good examples of what should happen across the board. But the reality is that those are outliers, not the norm, indeed, not even a fair sampling of what was going on. Some of you might have heard in the news early last year, when the pandemic first raged through Canada, that there was a huge problem in nursing homes across the country. In Ontario, with the largest number of nursing homes, but also across the country, including one in Quebec, where the army was called in because the staff had actually left. And what they saw when they came in was horrible. And the numbers don't lie. The numbers on the table in front of you just show you the number of cases, and the second table will show you the number of deaths. Now, these are as of February of this year, but last year, by June, the count of deaths and those in nursing homes showed that 81% of all the people who died in Canada were people who were living in nursing homes. So things obviously have improved with the shock of the situation. They got PPE, they got more staffing, they corrected a few structural issues. But even as of February, last month, the national average was that 68% of all the people who died in Canada were people in nursing homes. In Ontario, the number is 65%, and in Quebec, it's 75%. And when you look at those numbers in table 2, you see that in Ontario, there have been about 6,700 deaths in Ontario of all people. In the nursing homes, the residents, there were 4,200 of them. So 65% of all the people who died in Canada were in nursing homes, in Ontario rather, were in nursing homes. So while it is true, you can easily say, well, those people were very old and frail anyway, so it's like understandable that they would succumb rather easily. But that doesn't tell you the whole story. It tells you that there's something fundamentally wrong in how nursing homes are run, right, and their ability and resilience in dealing with an assault like this pandemic. Some of the things that came to our attention at the National Institute of Aging, one of the issues was whether or not family members would be immediately shut out. Well, people were, John has given an example of a good initiative to bring in family members. But first of all, you have to understand that family members are not just visitors. They actually provide care. And if they're not actually, feeding their loved ones, they're providing mental sustenance. And that is a contribution that needs to be valued, accommodated, and so on. But most homes, instead of proactively helping people, family members to come in and look after their loved ones, were actively preventing them. It got so that the National Institute on Aging and others actually petitioned the government to change the rules, to require all nursing homes to have a policy that would support the attendance of family members as essential caregivers to their families, so that they could come in and spend the full days with their families. Of course, it required the administration to give them some training in infection control, provide them PPE, and of course, organize their attendance. And many homes just had no more capacity to deal with that, or just refused. So there was quite a spotty experience across the country. There were some very good examples, but there's the general run was some very poor examples. So even in that one small thing where, yes, there was a shortage of labor, plus some people got sick, other people were afraid to come into work. So now they were short staffed, and yet they still would not accommodate bringing in family members to spell. So that's just one example. And that example talks to the structural problems in this industry, that there really is inadequate staffing, infection control is not at the best, it's not regulated adequately. One of the issues that came out and was highlighted and has not yet been fully resolved was that PSWs, personal service workers, were paid so poorly and given so few hours that they had to work at multiple homes in order to put together enough hours to form one working wage. Well, of course, they would be going from one home to the next, and they were considered in some cases to be vectors for the spread of the pandemic. Maybe they were unfairly criticized for that, but nonetheless, there was one opening, and all they had to do, which is what they did in BC right away, was absolutely forbid people from working from more than one home, but they also required them, the homes, to give those PSWs adequate hours within their own home so that they had a fair wage. Now, what has to happen across the board now that we are maybe less of a panic is to make sure that that necessity of people to make a living wage is addressed. either by increasing the working hours and increasing the hourly wage as a bare minimum. So these are lessons that we have that had to learn in tragic circumstances as a result of this pandemic. But if we don't learn from this and have some structural change, then it's going to fall to individuals doing their very best and doing, taking on heroic efforts, but that's not the way the system should work. So the advocacy has to be directed at government, and the demands have to be specific demands in national standards of care, increased hours of residency care, that is the number of hours that each residence gets from the nursing staff, the infection control protocols, the wage, and so on. These are the structural things that have to change across the industry.
Right. Just want to make one comment is those stats that you showed, Susan, are stats of COVID deaths. But there are a lot of deaths that are, I used to say collateral damage for the longest time, but now thanks to Nathan, I think it's Stahl, this like excessive death or excessive mortality due to a collapse of the care system. So those are not captured, those are not even captured anywhere. We don't know really. So those numbers that you quoted is the minimum of what we've captured, just to say that.
Well, Helen, one of the problems is that in this sector, there is such a high level of ageism that unless you have these pure numbers, right? Exactly, identified COVID deaths that are, unmistakable, there's actually a diagnosis and a death. Then if you try to argue collateral deaths, people say, oh, well, that's just fuzzy, too fuzzy. And then it sort of sinks your entire argument. So unfortunately, in this area, you're right, it's an undercount of the impact of this pandemic in the long-term care sector.
Right. And Ontario had the same opportunity that BC had to just convert them all. They knew that it's not a secret in anything in the industry, like the industry has seen a huge group of part-time, more and more part-time instead of full-time. In my HR background, I would look at that and say, there's something wrong there, because how can you do proper infection control when it's a revolving door of people in all sorts of different places with different protocol in homes and everything? It's very hard to manage. So it does have to go back to national standards, consistent across.
Thank you. John, do you have anything to add?
I think Susan and Helen have outlined the real challenges our sector has faced. I would say that there are bad actors in our sector, homes that definitely could have done more, but overwhelmingly, there are many homes like Kensington that have done everything possible to protect their residents with whatever resources they have. And I think my other point is around the willingness to partner outside the sector. So pre-pandemic, we had established a relationship with Women's College Hospital in their innovative long-term care plus program, which gives long-term care homes direct access to specialist care to avoid an unnecessary visit to the emergency room.
Wow.
That relationship paid dividends during the pandemic. So before hospitals were assigned to long-term care homes, I made a call to the CEO and I said, we need help. And within a week, personal protective equipment showed up. 20 of their staff showed up. We started testing bi-weekly before the province mandated it. They provided their infection control expert who went floor to floor and helped us really take the necessary hospital level infection control practices to the next level to prevent further deaths. And I think that is really where our sector seems to have been ignored, as Susan has said, and that we are part of the larger healthcare system. We can work together with other healthcare partners that have more knowledge, more skills, or competencies to be able to share it across the healthcare system. So the good news, or the silver lining in this, is that these partnerships are now very much common across the province. Many long-term care homes are now assigned to hospitals. And I think these positive relationships will continue to flourish post-pandemic. So we're not in a crisis situation, so that our seniors can receive the care they need without going to the hospital unnecessarily. And that if we do have concerns about the care, there's a quick expedited way to get that access into the home without the logistics of getting an ambulance transfer, putting the meds in the Ziploc bag because we don't have an integrated digital health system, calling family members who are scared as to what's going to happen, spending time in the hospital, and then transferring all the way back. It's very, very traumatic to the resident, to our seniors. So these partnerships aren't just for managing the pandemic. They're about managing care.
Definitely. I mean, like, there's some hard lessons to be learned really from the pandemic, but like, I guess like we're asking ourselves, like, these things should have been done a long time ago without having to learn from the pandemic. But at least I think we are trying to get something positive out of it. Before we leave the long-term care home issues, one of the things that I think, along with the inequities in the healthcare system, in our socioeconomic structure, I think the other thing that was very revealing in this test was that the death rate of seniors in for-profit homes is much, much higher than not-for-profit homes. Would you like to comment on that? And what do you think needs to be done about that? I know you talk about national standard, but how does that impact like the different ways that the homes are funded or organized?
Well, there's one thing to realize about how funding is conducted in the nursing home sector. I think it's true in all provinces that the nursing care, the food services, and some ancillary services are funded by the province under the healthcare system, and they are allocated funding based on hours per resident, a certain amount of dollars per resident for food, etc. And that dollar amount is regulated, and the services that are provided, the nursing services, etc., the food services, are all calibrated on a per resident basis and paid for by the province. And that's true in the for-profit homes and the non-profit homes. Actually, John should be talking about this, but I'm on a roll on this one, because the other part, that's the profit or non-profit, is what they call the hotel services. So theoretically, if you're paying for it separately on top of what the government is paying for nursing services, you should be able to dictate the level of, luxury that you would like to have in the hotel portion. That having been said, the two things are combined, and the nonprofit homes tend to, they don't take a profit. They pay salaries like everybody else. They don't overpay their executives. Some of the for-profit homes have executive salaries in the hundreds of thousands, like 500,000, $1.5 million in one sector, in one home that I'm familiar with, which is not really an expensive one either. So a lot of that money, the profit, goes into the salaries of executives. They don't pay their nursing staff any more than the nonprofits. And where do they cut corners? They don't provide ancillary services. They have the absolute minimum number of staff necessary to sop up the funding they get from the province. And whenever they create an atmosphere, I believe, that just isn't as conducive to people pitching in. And so you're not going to have a CEO rolling up their sleeves to help with infection control or resident care. So it's just not going to happen. So then you have the net result after this pandemic, where they indicated they added up the deaths in for-profit homes and non-profit homes, and they showed a poor result in the for-profit homes because their first interest is in shareholder value, and the nonprofits, we still hope, are focused on patient care.
Helen and John, yeah. Helen, yeah, go ahead.
Yeah, from an HR perspective, you know, the conditions of work are conditions of care, and there shouldn't be profit in care in my mind. But you know, the municipal homes did way better, and it was because there was municipal money put into those homes, and it was foresight of the mayor to do that and fundraising to get that. And I find that also like the Mennonite nursing homes or the Catholic ones sometimes have fared better, and the culturally diverse ones as well. The smaller homes are better, you know, because they can manage better. So in my mind, yes, you know, we should have standards, and if it's not profitable, then they can go somewhere else with their business, you know, and really respect the dignity of seniors.
I think that raises another issue, and a lot of when we started the Yihong Center for Geriatric Care and Mengshong as well, the focus was on culturally appropriate care. But there was also the need to convince the community to, you know, because it was a new idea to actually send your loved ones to a nursing home, because most families were very proud of their own filial responsibility, saying that, you know, we are going to look after our parents, and, you know, would be shameful to send the person to a home like this, right? In order to get them to actually support the creation of the nursing home, we had to convince them that, first of all, they couldn't actually manage at home, even though they'd like to. On the other hand, we also made a promise that this would be a home away from home, that it would have standards of care and environment and so on, that they would be not only willing to, you know, admit their loved one, but be proud of being able to secure a spot in one of these nursing homes. And I think that's the way it has continued. And the net result is that when you are faced with a challenge like this, these homes perform better, because they had actually made a promise to the community, and they were fulfilling that promise. I would suggest that the homes that performed poorly did not have that kind of attitude of care, that ethic of responsibility towards their residents.
John, thanks, Susan. You were.
This is a complicated issue. There's a lot of history, a lot of politics. Subsequent governments have underfunded long-term care, for-profit, not-for-profit. It's all the same in terms of the funding formula, as Susan really clearly outlined in a very layperson's way, because if I were to explain it, I would have been very technical about it. No one would have understood how long-term care homes are funded. My personal take is this, and this is not a view represented necessarily by Kensington, so it's my own personal view, is the evidence is clear. And the organization that Susan is representing, the National Institute on Aging, and Dr. Nathan Stahl, as Helen mentioned, have published a number of papers on this. The Toronto Star recently did, I thought, a quite comprehensive analysis. To me, the evidence is clear at first blush. What's complicated is what's underneath in terms of the capital builds, the 4-bed wards, the fact that municipal homes are, as Helen mentioned, it's property taxes that help reinforce the funding structure of municipal homes. So your property taxes help your local community, which I think is fantastic. Not-for-profits like myself, Yi Hong, we have great foundations that raise a lot of money to be able to offset some of those costs around replacing beds, topping up the food budget with organic fresh fruit and culturally appropriate meals. And the private for-profit homes have put up capital to build beds. So if you get rid of them, you get rid of the beds. Who's going to build the beds to replace? So to me, again, in my personal view is there's a not-for-profit, for-profit discussion that really is about one thing, and it's about value. And value really boils down to three things. It's about the quality of care. So if we talk about standards, what do we mean by good care for residents in long-term care? I could rhyme off 3 or 4 clinical indicators, 3 or 4 psychosocial, a whole bunch of other indicators related to well-being and wellness. But the quality is one dimension. The service component is another. And Susan and Helen talked about the culturally appropriate piece, the resident experience, the family experience, what they perceive as good service. We know when we go to the Four Seasons what good service is. We should be able to understand when you enter a home what that service is going to be like. And the third piece is about price, and that is set by the government. But if you put those three things together, you will come up with a value equation that, if we're going to talk in for-profit terms, consumers make the choice. So if there was an equal opportunity to choose a for-profit or not-for-profit, you would choose the best value, and whether it be not-for-profit or for-profit. So that's kind of how I break down the for-profit, not-for-profit. If we're going to talk in those terms, let's talk about market, and the market rules dictate that the best value always comes out ahead. Just think, so that's how I personally view it. Now, if I were to put on my Kensington CEO hat, the view would be not-for-profits are mission driven. Our values are a little bit different. We are incented in different ways. We're not motivated by shareholder value. We are about service and about serving the community. And that alone is a key differentiator. So I have 2 points of view there.
Definitely. Thanks, John. I think the evidence, as you say, is quite clear, right? And I think that is dictated by our values and our commitment to community and to service. So I really, really appreciate this discussion. And I think we would be remiss if we don't talk about the other parts that we have kind of planned to bring up, which I think, John, as you said earlier, having that partnership with hospitals streamline some of the tertiary care and more complex medical problem when people in the homes, presents with more complication. But then the other part I think Helen talked about earlier is, her grandmother was able to live to over 100 years old before she has to move to home. So there's a lot of our seniors who are in the community, and how we provide care in the community definitely has a huge impact on the system, right? So maybe we can move on to our next part of the scenario to continue our discussion. So if we can share screen on the second scenario, and Helen, would you like to take us through again?
Okay. The spouse of, so we're talking now about the spouse of the person that was in the long-term care facility now, okay? So the spouse of the elderly senior is relatively healthy and is living on his own and is waiting for spousal reunification. Prior to the outbreak, he was visiting his spouse daily in the nursing home. Since the outbreak, he's not allowed to visit. His own health has steadily declined, and his home care visits were reduced. Community agencies started to deliver services online, and he was finding it hard to access any support.
So let's have some poll to kind of help us reflect on what we could do as an individual family member, as nursing home management, and as government. So if you can respond to the poll, That would be much appreciated. You have 2 minutes to do that. So if you're a family member, what would your response be? You can use technology, and I think earlier we mentioned that more frequent in-person visits to help, advocate for better home care, advocate for expanding spousal reunification programs, uh, and other suggestions. If you are the nursing home management who the person's spouse is currently living in, what can you do? More tech support to help families stay connected, increase counseling support for family members, mobilize volunteers to support family members who are not in the home, open up or expand day programs, work with other agencies to coordinate community-based senior support, and other suggestions. And government, do you want government to fund more subsidized options for supportive senior living, provide financial incentive for family caregivers, provide financial incentive for business to address senior needs, expand community services targeting isolated seniors, or other suggestions? We are closing the poll in 5 seconds, so your input is very much appreciated. So thank you for your response. Again, we'll maybe Helen, you can comment first on the scenario.
Oh, okay. So I think in terms of the family response, it would be all of those things. First, to just secure the person. So using technology like fall detection devices. I've Echo Show we've been really successful with, where the senior doesn't have to do anything and the family just drops in and you can see them and you can see how they're walking, you can see how their health is, their pain level, all of those things. I find that technology really is beneficial. In terms of the spousal reunification, there is a bill that is Bill 153, and it's till death do us part. And it is like to try to get the spousal reunification in the same home, because sometimes they can't, and you know, they're separated, and that's a horrible situation. So there is a petition and a bill forward for that. I think in terms of my grandmother's experience and my experience, you know, she lived in her own home until she was 107, you know, 3 floors, basement and attic, up and down the stairs on her own. So I really feel that she is a model for us to look at, and that it's aging in the right place though, for the individual, depending on their health situation. So seniors, in my mind, need a variety of different selection of how to live, where to, like how they would live, and at what time. So I feel that strongly. They should not just have one option, like go to a long-term care facility and have no other options. I think we need to be looking at a variety of different living options and have it culturally and linguistically appropriate for them. And more like lease for life arrangements, assisted living, all sorts of other options for our seniors. They deserve it.
I agree, Helen. I should note my mother's on the call, so hi, Mom. And I will take care of you. Don't worry. And I think I should mention this is actually was mentioned earlier around Asian values, and not just Asian, but certain cultures do value our seniors differently. So, you know, my mom, when I got married, I think, and my wife's also Asian, there was a sort of unwritten rule that at some point our parents would most likely move in with us. That was the expectation. And, but I think, Helen, that your point is really about this new, well, not so new, I think the terminology is new, and it's called naturally occurring retirement communities. So that it is very organic, you move based on your needs, but it is all very local, intergenerational, it's neighborhood based, so you can go to your local supermarket, buy Asian pears or bok choy. You can go to your local community center and da mahjong, right? Like play mahjong. You can go visit your GP, senior services, and you can transition from one type of housing arrangement and go down the street to a long-term care home if needed. But in the case of the case study, the spouse, if we were in this naturally occurring retirement community, that spouse could walk across the street and be part of that community and be part of that care team. We don't think of seniors living the way that some of the Scandinavian countries in Sweden and Denmark, who are leaders in really supporting these types of communities. You hit a certain age, you're warehoused, you're institutionalized, and you're forgotten. But Monshong, Yihong are good examples of developing campuses of care, at least the Markham location, Monshong, and there's no room at Darcy Street. And Yihong across its 4 sites as well, really taking that concept and really driving that home around that community that's built. So you can move as you age and get their appropriate supports. And certainly technology can lend a huge hand. Some of you may have read about Alphabet. So Google had partnered with Waterfront Toronto around with Sidewalk Labs around the Quayside project. And I had spent quite a bit of time along with other community partners to really reconceptualize this idea of naturally occurring retirement communities in a verticalized way, so that the top floor would be really market-based penthouse, and then as you go down the floors of a, say, 20-story condo, that the ground floor would be long-term care. But in between the floors would be intergenerational, so young couples, young professionals, kids, assisted living, life leases that you talked about, Helen, and that it would be all wired. So privacy concerns aside, but the ability to exchange data in a building alone, we would get into the point where it'd be predictive, that you could know when a fall may occur and someone on the floor could come and help you before that fall were to happen. So there are ways to rethink and reconceptualize how our seniors are living, how they live in the communities, and how they live together.
I would want to add to that, and I agree with both of what you have said. But I think what we have to do is start from scratch and not hope that the various nursing homes are going to expand back out into the community, but rather we create a situation, as you say, John, that people start, in middle age, and then as they age, they access more and more supportive services, and they don't need to live near a nursing home. They have to be able to access these kinds of services in their own home. That having been said, that whole concept of home care or home services exists in theory, but it does not help you if you need more than a sporadic number of hours a week and can live with days where somebody doesn't show up at all, because no one has bothered to organize your access to, say, personal services workers every day if you need it every day. So therefore, to stay at home, you can only stay home up to a certain point. And then suddenly from there, you have to leap straight into the waiting line for a nursing home. So what you need instead is to fill in that gap that allows you to access the kind of supportive services from your home in your neighborhood. So either in your home, in the daycare facility that's located in your neighborhood. One example we explored was the concept of community hubs. A lot of residential communities now find that very few young children are being born in their community. People have grown old in these communities, the children have moved away, and the schools are sitting empty. And so they're being switched into condos. If they didn't do that, if they planned ahead and started to use the footprint of the school as a public service hub, public healthcare, senior center, other recreation, maybe educational facilities, and some residential care, day residential care if somebody needed it for rehab from a hip operation, as well as people who have dementia, so that you basically stay in your community as long as possible. You mentioned the Scandinavian example where Denmark made a commitment that they would not build another new nursing home, right? And they committed, therefore, to providing all of these services that were necessary in people's homes. The trouble is, with some of the changes in government, they cut funding for those services. So now they've got the worst of both worlds. But we can start doing some of those things here. For example, in some smaller communities, maybe not possible in Toronto, but they have started to have emergency services, the EMT. They're not always running around in ambulances in these smaller communities. They do have, like fire trucks are not careening around the streets all the time. They do have empty hours. So the EMT have routes where they visit, housebound seniors. And in fact, they have a route. And they go in and see the person at a given hour, take their vitals if they're monitoring them for, say, diabetes care or whatever, check that they're okay, that they don't have any problems in the home. They don't bring them meals, somebody else does that, but they check on the health situation. So basically you have a mobile nursing home in that circumstance to some extent. So those are opportunities that we can actually introduce now. And some communities in Canada have started to do that. So we have to start with the premise that you stay at home as long as possible. You notice that in answer to the poll, it was all of the above. Everything is over 75%. And that is because people recognize now that there's an opportunity to alter how we care for not only our senior loved ones, but ourselves as we get older.
Mm-hmm. So I think it's really important that, we look at these as lessons that is not really just for crisis management. And I think, as John talked about earlier, really is a lot of these lessons we should be mindful, from before the pandemic and certainly hopefully after the pandemic. And a lot of the issues similar to what I raised earlier about for-profit versus not-for-profit long-term care facilities. I think in terms of home care, we also need to remember that there is a huge erosion of home care services funding over the years, right? And that's why everything is quota, with very limited support. So I think we all agree on the need of augmenting community-based care, integrated services, having a community-based mutual support kind of model. But I guess I would maybe, as we moving towards the end of the session, I would like to, and certainly throughout tonight, we've heard a lot of really inspiring work and examples and wise practices from the community and from the frontline service levels, right? And from management of frontline services level. I think it's important that we do hold our governments and policymakers accountable and build systemic changes that would safeguard the interest of our communities and our seniors. So I would invite our panelists to maybe make a closing statement and call for action, having reflected on all these hard lessons that we've learned through the last year. What would you think would be something that you want to call our community to act together towards advocating for? Who would like to start? Helen,
Okay,
actually, Yeah,
Oh,
okay.
well, I will then in that case. I think that we need to be less grateful for the people who are running our nursing homes. John is the exception here because he has taken on so many heroic initiatives, but the vast majority of nursing home management have not actually responded. It is true that structurally funding is inadequate, and there are ways to address that. But management also has a responsibility to meet the highest standards, not just the kinds of standards that they demonstrated during this crisis. In order to have home care be better funded, maybe it needs to be part of the Canada Health Act. It is not at the moment. And so it's very spotty across the country. We have to challenge ourselves to decide that we want to put a value on seniors' care in a positive way, rather than thinking in terms of warehousing, which is what the system, the industry seems to be doing now, with very few exceptions.
Thank you. Maybe John?
Yeah, I'll be quick because my mom is on the line. Care starts and ends at home. So take care of your loved one. It starts there. And if we do that, it will spread and be, it will really help our seniors in long-term care. So when you can, give them a big hug. Care starts at home.
Thank you. Helen?
Oh, John, now you're going to make me bawl my eyes out. That was so amazing. From a change perspective, I have to say that, you know, with the pandemic, it has really shown how all the vulnerable populations have been impacted, and it provides quite a compelling case of urgency. In my mind, I think that, you know, it's close to genocide. So I think we're at a tipping point, and I do think that we have to roll our arms up and really pressure the government in making substantive changes in all areas, and be bold about it, because it's been decades, you know, like I remember, so it's decades, and it's about time. I want to know, how many lives do seniors have to lose? Do healthcare workers have to lose before somebody stands up and take a note of it, you know? I mean, we didn't even learn from SARS, and we certainly learned only a bit from wave 1, because we saw the wave 2 data, and I am just appalled. So I do think that we need to stand up and roll our sleeves up and shout it from the rooftops. I mean, seniors deserve much better than this. And my grandmother, she spent, you know, she was a social activist in her late senior years, and her last days on this earth, she was highlighting the plight of long-term care residents, okay? So her death is not to be just the statistics that we saw in any of those charts. And all the seniors' deaths that have occurred during the pandemic. It is a call for action for senior rights across the country. And I invite everyone to join this fight, because it was fragmented at the beginning, but we're gaining, and we're getting solid, and it's coming from the bottom up with grassroots organizations, and it's coming from the top down in terms of academics, doctors, lawyers. So there, you know, we're gonna do it. We just need to keep going. And this is the call to action. Write to your MPPs about the need for long-term care transformation and the neglect of seniors. Write to the Premier, write to Prime Minister Trudeau. I've done all of those things, and I continue to do it, like every holiday and every milestone. Share information on your social media platforms. Really, it's really important. And I can't really see the next one now, but attend the Tuesday weekly 10+3 town halls. 10 meaning 10 provinces, plus 3 meaning the 3 territories. They're starting at like 4 and organized by Canadians for Long-Term Care. They're amazing workshops that town halls that are leading up to a National Day of Action. And that's on April the 27th. And that's my birthday. And I can't think, I would rather celebrate it a different way, but yeah, I don't mind celebrating it with a protest and come in solidarity. You know, it's a full circle to my younger days in terms of advocacy. And it's a shame that we're having to continue to come out and do rallies, but this is needed, and it's so important right now for our seniors.
Thank you, Helen, and thank you, John, and thank you, Susan. And as Helen reminded us, today is an anniversary of the pandemic's date of remembrance, and I feel really privileged and grateful to have all of you joining us on this very important discussion. And I think having that spirit of activism, that spirit of care that we've shared in this discussion really has been very inspiring and helped me personally. And I think as hopefully it will continue to support the building of momentum of this very important work forward. So I'd like to really thank you for spending this evening with us. So I would invite our participants to fill out our exit poll. And also I would like to remind and invite all of you back next week for our special session on vaccines. Everything you wanted to know and are not afraid to ask about vaccine. We're gonna have our representative from Toronto Department of Public Health, our counselor Christian Wong Tam, and internal medicine specialist Dr. Stephanie Go join us. So please do tune in and join us for the next discussion. But I'd like to really show my appreciation and gratitude for all of our panelists tonight. And I wish everybody a safe and healthy evening and beyond. Thank you. And we will post the information on our website. And also, if you check our website, John has a very active social media profile. So you can get on his Twitter, and people have been asking for the contact of our speakers. So you could check our webpage. And also, this session will be posted on YouTube tomorrow. So please invite your friends and other contacts to check out our video. And I think we would continue to build our community. Thank you and good night.